So this whole morning is going to be, I'm just really excited about this, and I've been excited about this for some time now, because we had the chance to get these two people here together, and I don't know how we did it, so really feel very honored that they're here today. The first is Dr. Gabor Maté. He's a retired physician and the best-selling author of 4 books published in 27 languages. And as many of you know, he's internationally renowned speaker. He's sought after for his expertise on addiction and trauma, childhood development, relationship of stress and illness. And his book on addiction received the Hubert Evans Prize for Literary Nonfiction. And for his groundbreaking medical work and writing, he has been awarded the Order of Canada, his country's highest civilian distinction, and the Civil Merit Award from his hometown as well. I could go on and on about Dr. Maté, but I'm going to let him make sure that he has all the time he can with us today. He does have a new book that's coming out that really promises to be something special. It's called The Myth of Normal: Trauma, Illness, and Healing in a Toxic Culture, which is coming very soon. And then also his colleague, Dharam Kaur. She's a neuropathic doctor, author, and an expert Kundalini yoga instructor practicing in Ontario. She's been working with Dr. Maté since I think it's 2012. She was awarded the Naturopathic Doctor of the Year Award in Ontario in 2000. She's written 3 books, and they have worked together on this compassionate inquiry therapeutic model for a number of years. So please, without further ado, welcome Dr. Gabor Maté and Dharam Kaur.
Thank you. So, good morning. Thank you all for being here. David, for inviting us. It's my second time here in Charleston, and it's great to be back after the interdiction of the COVID years. I'll tell you a little bit about why the two of us are together, and then Dharam will lead us in an exercise. So, as a family physician, at some point I began to realize that the illnesses that I was treating people for, whether they were in the so-called mental illness, and I say so-called for good reason, or the physical illness category, they were not isolated, discrete events in people's lives, that actually they represented events and dynamics in people's lives. In fact, when you think about illness at all, just the way we speak about things reveals a lot about the underlying ideology with which we hold those concepts. Now, we don't think of psychology or psychiatry or medicine as ideologies. We think of them as scientific disciplines, particularly in the medical field. And of course, there's a lot of great science and indispensable science involved in the practice of medicine. But there's also ideology. And by ideology, I mean there's certain assumptions that we make that we don't question. And we don't even realize that we have these assumptions. That's what an ideology does. It imposes a certain point of view on it, but you don't know that you have a point of view. You think you're looking at reality, whereas you're looking at reality through a certain lens. So let's take the concept of illness just for a moment. If somebody says, so-and-so has ADHD, so-and-so has depression, so-and-so has borderline personality disorder, so-and-so has multiple sclerosis, so-and-so has rheumatoid arthritis. There's an assumption in that way of speaking. What's the assumption? The assumption is that there's a so-and-so, so if I say, I have ADHD, and by the way, I have been diagnosed with that condition myself, you can say, so Gabor has ADHD. That makes the assumption that there's this person, then there's this condition, and that person has that condition, but the person is separate from the condition somehow. Like I have a cell phone, I have it, the cell phone's got its own nature, which is quite independent of my own nature. I have it, I can give it away, I can throw it away, I can use it, I can put it in my pocket. But it's distinct from me. Or so-and-so has rheumatoid arthritis. There's this entity called rheumatoid arthritis, which has got a trajectory and a prognosis and a life course of its own. Then there's this person who has it. But is that accurate? Let's take something, it's rather circular when you think about it. When you say somebody has ADHD, so Gabor has ADHD. How do we know? Because his mind tunes out. Why does his mind tune out? Because he's got ADHD. How do we know that he's got ADHD? Because his mind tunes out. So it's a kind of a circulatory, so the first point is, I began to realize that diagnoses don't explain anything. They describe things. That description may be helpful and useful and practical, but it doesn't explain anything. So never explain anybody's state by saying it's because they have this condition. Now the other assumption is that this thing that they have is independent from the person. So if you have rheumatoid arthritis, it's got a certain course. If you have multiple sclerosis, it has a certain course, a life course. It could be chronic, or it could be remitting, relapsing, or whatever category you're given. But it's got a course of its own, a trajectory of its own. What if that's not the case? What if any of these conditions, whether in the mental health or the physical health field, actually are manifestations of people's lives? What if they're not things that people have? What if they're processes? And what if those processes reflect somebody's life history? Well, if that is the case, if these processes reflect somebody's life history, then if that person can gain agency over their life process, quite possibly they can have some agency and influence over that so-called thing that they have. And that is actually the case. That is actually the case, whether it comes to what we call mental illness or physical illness. So when people change the processes of their lives, that so-called disease proves itself not to be an independent entity with a trajectory of its own, but a reflection of that person's life and process. Now, this is not a realization I came to like that, but it gradually began to dawn on me. And furthermore, this process that I'm talking about reflects the person's entire life, beginning with the family history in the multi-generational context, in the context of a certain culture. Let me give you an example. From the physical health field. Asthma. So asthma is an inflammation of the airways, of the air in the lung, and a narrowing, constriction of the airways. We've known for decades, multiple studies have shown, that the more stressed the parents are, the more likely the child is to have asthma. We further know from studies that the more episodes of racism a black American woman has to endure, the greater the risk for asthma. Which means to say, is the constriction of the airway and the inflammation in the airway a question of individual pathology of a particular organ in a particular distinct body? Or does it reflect a life history, personal and social relationships? Which is clearly the case. And I can show you the same dynamics in virtually any illness, physical or mental, that we're cared to look at. For example, a study out of Harvard 3 years ago, the more severe the symptoms of post-traumatic stress disorder a woman experiences, the greater the risk for ovarian cancer. In fact, it doubles. Severe PTSD doubles the risk of ovarian cancer. We've known for 100 years, literally 100 years, or more actually, no, 150 years, that depression is associated with breast cancer and breast cancer prognosis. Intuitively, physicians have noticed these things for a long time. Science has come along and has shown it to be actually the case. Well, if that is so, that also means that if we can address the source of depression in a person, we can actually have an impact on their risk or their prognosis with breast cancer. But when you look at depression, if we don't think of it as a illness, this brain disease model, which is largely what psychiatry has embraced in the last decades, that is, we're all talking about biological diseases of the brain here. If you don't think about depression as this biological disease, then what is it? What if the disease model doesn't explain it? By the way, I'm not arguing against proper treatment. I've been diagnosed with depression. I've taken antidepressants. They helped me in my 40s. In fact, they helped me tremendously. But it's never been proven. You know how much evidence there is for depression being a physical disease due to lack of serotonin, which is what the story is? We give these serotonin-enhancing medications, the SSRIs, like I took fluoxetine, Prozac. Therefore, the assumption is, and sometimes it works. It worked for me. Therefore, it must be a biological disease caused by lack of serotonin. You know how much evidence there is for that? Zero. None. Zilch. Nada. Nothing. And yet we keep on talking about it as if it was a reality. The fact that the Prozac helped me doesn't prove anything about causation. Think about it. If you go to a party and you're socially shy, and you're kind of standing in the corner by yourself, and you have a drink, and all of a sudden your tongue loosens and you become voluble and life of the party, does that prove that your social shyness was caused by a lack of alcohol in your brain? If you have a headache and you take a Tylenol, acetaminophen, and the headache subsides, does that prove that your headache was caused by a lack of acetaminophen in your brain? So there's all these assumptions, people, that we're making. I think it's essential to question these assumptions. And the reason it's essential is because look how we're doing. The rate of childhood suicide is rising in the United States and elsewhere. Big articles in the media just a couple of months ago about that. The number of overdoses in this country has now reached or has exceeded 100,000 per year, 100,000 in 1 year. Many more Americans die of overdoses than died in the Vietnam and Afghan and Iraqi wars put together. And it's not getting better. Rates of childhood diagnoses like ADHD and anxiety and so-called oppositional defiant disorder, which doesn't even exist. I can talk to you about that later if you want me to. All this is going up. And the assumption is we just have to keep doing what we're doing harder and better. But what if the problem is not that we're not working hard enough? What if the problem is not that we're not committed enough and dedicated and diligent enough? What if the problem is that we're not looking at it from the proper perspective? What if we need a fresh understanding of what's going on? A friend of mine, Louis Mel Madrona, who's an American physician, I think he's also a psychiatrist. He's from the Lakota tradition. Some of his ancestors are Lakota. And he said in the Lakota tradition, when somebody gets ill, the whole community gathers and says, thank you, because you're manifesting the dysfunction of our community. And therefore, your healing is our healing. But what if we actually understood not just what ancient tradition has told us, which is that you cannot separate mind from the body, and you cannot separate the individual from the community, and you cannot separate the individual from nature, or from spirit, if you like, however you define it. What if it's all one? What if we actually embrace that ancient tradition, not because ancient traditions, indigenous cultures tell us that, but because modern science has proved it over and over and over and over again. Thousands of studies have shown a relationship of illness and trauma, how trauma physiologically triggers illness. I could mention all kinds of studies on that. I won't right now. How inflammation itself is exacerbated by trauma. How all mental illnesses, the more trauma accrues in a person's life, the greater the risk for any mental health condition. How, despite our genetic obsession, there's very little actual evidence that genes cause mental illness. In fact, nobody's ever found a single gene that causes any mental health condition. Nobody's ever found any group of genes that determine any single mental health condition. Nobody's found a group of genes or single gene that in the absence of it, you cannot have a mental health condition. What they have found is that there's a large nebulous, very large, very nebulous group of genes that the more of them you have, the more likely you are to have any number of mental health conditions. But that means that the genes don't determine the condition. They determine your susceptibility. The rest has to do with the environment. And the environment has to do with trauma. Now, what I've just given you is a brief overview of what I've learned, not just when I was in family practice or when I was working in addiction medicine for 12 years in North America's most concentrated area of drug use in Vancouver, British Columbia, but also what I've learned since then as a follower of the research and as a writer and as a teacher. But in family practice, I began to glimpse these truths, not because anybody taught them to me, because they didn't. The average medical student doesn't get a single lecture on trauma. Didn't in my day, most of them don't now, except physical trauma, of course. Or maybe in the very narrow context of what they call post-traumatic stress disorder, but not in general when it comes to mental health or physical illness. But I began to see these things. And that meant that when somebody came down with a diagnosis of, say, multiple sclerosis, let's say multiple sclerosis, or let's say depression. Well, you know something? In 1860 or so, the first person to describe multiple sclerosis, the French physician Jean Martin Charcot, said that this is an illness caused by vexation and grief. He saw it. He's the one that described the illness. Since the 1870s, we've had dozens of studies showing the relationship of stress and trauma to multiple sclerosis, to flare-ups, to disease severity, and so on. I mean, multiple studies. You go to the average neurologist, they'll never ask you about trauma. They'll never ask you about your childhood, about stress in your life, about your relationship to your partner, whether you have a partner, about how you feel about yourself as a human being. Because they're not trained to ask these questions, because we have this ideological lens of the biological entity and the separation of the nervous system in this individual discrete body, and we're not looking at the whole context. Same with rheumatoid arthritis. A great Canadian physician, William Osler, who was one of the founding doctors at Johns Hopkins, by the way, he said that rheumatoid arthritis is caused by long-term worry and stress. Dozens of studies in this century or the previous century has shown how right he was 150 years ago. But you go to the rheumatologist, anybody's going to ask you about trauma or stress? Nah. Because we make this separation. The same with mental illness. Depression is this mental illness. Okay, that's one way to look at it. It has features of an illness, yes. But is that an adequate way to look at it? Just look at the word itself, depression. What does it mean to depress something? It means to push something down. That's what it means. What is pushed on in depression? Your emotions are pushed on in depression. That's what's pushed down. Why is it pushed down? And what I found, and this is the essence of what we call compassionate inquiry, is that there's a reason for everything. And there's a reason for everything within that person's life history. And there's a reason for everything within that person's life history in the context of the family, the multi-generational family, the culture, and the larger society. Do you think it's accidental that in Canada, an indigenous woman has 6 times the rate of rheumatoid arthritis than that of anybody else? The Pope is in Canada right now apologizing for what the church did to the native people, how they traumatized the children in these residential schools where Canadian, they're not Indian, indigenous people, children were sexually, physically, emotionally abused for over 100 years. These people never had autoimmune disease prior to colonization. Now the risk of a woman, and why a woman? Because women have the double whammy of being the stress bearers of a society, and if you're indigenous, even more. Therefore, they have the same thing is true in the States, by the way, the same statistics. So what is pushed down in depression? Were your emotions. Well, why would you do that? Well, there's a reason for everything. What if you're a small child and one of the essential needs of children, one of the irreducible needs of children, when I say irreducible, I mean needs that if you take them away, there'll be negative consequences. One of the irreducible needs of children is to be able to experience all of their emotions. Now, in our brains, as has been shown, there's a circuitry for anger. Anger is a good thing. If you enter my space, physically or emotionally, I better say, no, stay out. That's healthy anger. That's all we share these circuits, by the way, with all mammals. We have anger, we have circuits for grief. Essential. Grief is essential to process loss. We have circuits for panic. If a little infant is left by themselves, they should panic. They should panic. So they'll cry and scream for help. We have circuits for play. We have circuitry for lust. These are the emotions. Now, why would anybody push down their emotions, given that these emotions are essential for survival? People would push them down only if doing so serves the purpose. All right, let's say you're a 2-year-old kid. I'll give you a simple and perhaps trivial example. And you want a cookie before your dinner. Now, if your parents are doing the job, they're going to frustrate you. If you don't frustrate your 2-year-old, you're not doing your job. Because you're not going to give them a cookie before dinner. Kid will get angry. You've seen this. Nothing wrong with the kid getting angry. Oh, you're angry. You really want that cookie, don't you? Yeah. But what if the parents listen to any number of toxic psychologies that tell you that anger is not tolerable in a child, and good little kids don't get angry? And when they do get angry, what you do is you give them a timeout. Timeout means you deprive them of your presence, and above all, you break the connection with them emotionally. The message the child gets is that they're not acceptable to you. If you do this over time, the message the child gets is that they're not acceptable to you when they express their anger. What will the child do? The child now has this decision to make. I can have my authentic emotion, or can have my attachment with my parents, but I can't have both. Now, attachments being the essential need of the human child, a secure attachment being the essential need for healthy development and even survival, is not a choice at all. What's going to happen is the child will push down their anger. Not consciously, not deliberately, but the brain will do this as a protective, adaptive mechanism. They depress it. 20 years later, whenever, they're diagnosed with this disease called depression. But the depression was an adaptive mechanism in the first place. It manifests the child's history, and not just the child's history, but also the parent's history. Because the parents will parent the way they were parented very often, or unconsciously they will transmit the same dynamics as I did to my children. I passed on my trauma to my kids. I have 3 adult kids. I've said to them, I screwed you up, I'll pay for your therapy. It's inevitable. We just do this. I'm not blaming anybody here. So, where am I going with all this? As I began to realize these connections in these dynamics, I realized when people come in with depression or multiple sclerosis or whatever, it wasn't enough for me to give them medications or send them to the appropriate specialist. I had to talk to them. Above all, I had to listen to them. And I began to ask questions. And the reason I did that is because in a part of Vancouver where I worked, my clients could not afford private psychologists because they're not paid by the medical plan. Psychiatrists are paid by the medical plan, but most of them were not trained in this kind of therapy. They were trained mostly in this biological model. Therefore, I had to step in. So I began to develop some skill and some capacity, very haltingly, and making lots of mistakes along the way in asking the right questions. That's what became compassionate inquiry, and how it became compassionate inquiry is because of the intervention of my friend Dharam, who at some point saw me work and said, why don't you teach what you're doing? I said, I can't teach it because I don't know what I'm doing, I'm just doing it. It's not a method I've developed. She said, yeah, you can teach it. And I said, no, I can't. And we backed and forth for a year or two over this, and finally Dharam organized an event in Toronto where she lives on compassionate inquiry with Gabor Maté. My fervent hope was, and I'm being as sincere as I possibly can be, is that nobody would show up. Because I did not want to expose my utter incompetence in front of a whole bunch of professional therapists. Unfortunately, 300 did show up, and so we did it, and lo and behold, it was a success. And so since then, not me, I didn't do this, Dharam did this, based on my work and precepts and what I've learned and how I articulate it. She developed this course called Compassion Inquiry, which is now a year-long training online, and we've had, I think, 2,500 or more people over the last 3 years in 80 different countries studying this program. And David has invited us today to demonstrate some of it, give you a little bit of a taste of it. But I have to own here that this wasn't my particular accomplishment. Yes, it was based on what I've learned and developed, but the program itself would not exist. It wouldn't even have been exist in theory, let alone in practice, without the vision and organizational skills of my friend Dharam, to whom I'll turn over the mic now, because she'll lead you in a particular exercise, and then I'll come back.
Thank you, Gabor. So one of the most important things when we're working with a client with compassion inquiry is that we're really present within ourselves and present with the client. So I'll lead you through a little grounding exercise to develop that presence. First of all, get comfortable in your seat and notice what that is for you to be comfortable in your seat. And begin to notice your breathing, as though you're simply hearing and feeling the breath. Hear the sound of the breath. Feel the air coming in through the nostrils, filling the lungs, then leaving. Notice the quality of your breathing. Is it shallow or deep? Is it slow or fast? Be present with that. And now bring your attention to the soles of your feet, wherever they are, and move them a little bit or press them into the floor. And simply feel that. And now come to your buttocks sitting in your chair or wherever you are right now, and sense the weight of your body resting on your seat. And now notice how your spine is, how you're holding yourself. Feel into the shape of your spine at this moment. And if your back is against your chair, feel that contact between your back and your chair. Feel into your shoulders. Are they relaxed? Are they tense? Simply notice what you're sensing in your shoulders right now. And now down into the arms and your hands, and notice where your hands are resting, the contact between one hand and whatever else it's touching, and then the other. Now come to the chest. You can be aware of your breathing, but also notice, what do you feel in the area around the heart? Is there constriction? Is there openness, relaxation? Bring your attention to the heart. Is there calm? Is there agitation? And now to the throat and the jaw. What do you notice in the jaw? and the forehead and around the eyes. Keep your attention on what you're sensing in your own body. And now let your awareness be open to any signals from the body that want your attention in this moment. Where is there constriction? A little bit of constriction. Where is there a little bit of tension? Allow your awareness to settle there, bringing it some attention. And as you feel into that part of the body, notice if there's any emotion there. Does that part of your body contain the flavor of one or more emotions? And give that emotion a name if you sense it. Be present to that for a few seconds. Allow it to be there. And if you're still present with that emotion, ask yourself, if this emotion could speak, what would it say? Wait for the response. And acknowledge that response within yourself and the truth that may exist in that response. And now come back to your breath. Pay attention to the air coming in, the air going out. Stretch that breath just a little bit. Deepen the inhale, deepen the exhale. And if there's a gesture you could do with your hands to hold yourself, if that feels appropriate in this moment, move your hands in a way that signify that you're able to be with what's present for you. Maybe it's 2 hands on your chest, maybe you're hugging yourself, maybe 1 hand on your belly, 1 hand on your chest, whatever feels good to you. And stay with that for a few seconds, giving yourself compassionate attention to whatever arises. Being with what's present for you in this moment. And take a few more slow breaths. And then relax your hands down. And when you're ready, open your eyes and come back to this group space that we're in. Just open to the energies that's present in this community of people right now. Thank you.
Thank you. In compassionate inquiry work, it's essential that the therapist, as Dharam has just guided you through, is aware of their own processes. Very often we think that this is a difficult patient, but I got news for you. Who's having the difficulty? Me, the therapist. That difficulty shows up in my body in a form of tension. So one of our mantras is, whenever there's tension, it requires attention. And that tension is in you. Now, the pioneering psychiatrist, Dr. Daniel Siegel, many of you I'm sure know his work, talks about his concept of interpersonal neurobiology, which has two meanings. One is that he actually set out to study the mind, and he brought together people from all kinds of disciplines: sociology, psychology, psychiatry, physiology, neurology, archaeology, physics, and all these people came together to arrive at the definition of the mind, which actually has to do with the fact that the mind is not a separate entity, that our minds are in interactions with other minds. Therefore, neurobiology, the biology of our nervous system and our brains is very much affected from childhood, in fact from in utero onwards, by the minds of other people. I'll say more about that in a moment. But the other obvious meaning is that when you're interacting with somebody, two nervous systems are interacting with each other. Not just two minds in the sense of what ideas or beliefs you hold, or even what emotions you have, but what's happening in your autonomic nervous system, what tension you have. Now the client is in a very vulnerable position. Any tension that you have, guess what? They're going to pick up on. There's one study I recall where they looked at the brain-heart coherence of both therapist and client. When both of them were congruent, now they didn't know, the client and the patient, or the therapist didn't know what the monitor was showing. But whenever the monitor showed that they were in coherence, that's also when the client and therapist would report moments of good interaction. And then when the nervous systems were not coherent, there was more dissonance between them. So what you have is two nervous systems regulating one another, two autonomic nervous systems regulating one another. Part of your job as a therapist is to help regulate that person's unregulated autonomic nervous system. Now, regulation develops in childhood, in infancy, as in fact already in the womb. If that client had an environment where there was good regulation of the nervous system, because the adults themselves were regulated, they were calm, they were coming from what Stephen Porges calls the ventral vagus, the social engagement, calm, present state. If the adults in that infant's and child's life had been coming from that position, that person would not be in your office in the first place. It's because they lack those conditions. Therefore, they're coming to you, to one degree. Whatever problems they're focused on, whether it's relationship or job or self-esteem or whatever, but in a deeper sense, they're coming to learn how to self-regulate. If you're not regulated, it doesn't matter how good your insights are, you're not much in a position to help them. And that's why I say that whenever there's tension in you, it requires your attention. And whenever there's tension in you, that's because something in you that's unresolved is being triggered. So when people join the Compassion Inquiry program as students, therapists, psychiatrists, whoever they are, they think they're coming to learn a technique. They're not. They spend the first 3 months learning about themselves. And the most important work you'll ever do is on yourself. And that's on an ongoing basis. So whenever there's a problem with a client, primarily look for the difficulty in yourself. what in you is resisting or is doubting or is upset? What in you?